Welcome, Dr. Bergman and Dr. Master.
Thank you. I'm going to share my screen so everybody can see the slides.
And I'm going to spotlight you as well.
Sure. Okay, and then we can make that full size. You want me to try it? I can do it. Let me do it. Okay. Hi, everybody. Spinal cord injury is complicated. Systems in the body can't communicate with each other as usual. So in order to stay healthy, we need to establish specific routines that take the different physiology into account. That's what rehabilitation is for. But today's healthcare system is in crisis, and no one knows that better than people with SCI. Our system is so fragmented that it gets harder every year to get needed equipment, medications, and supplies. It is even becoming harder to establish the routines themselves in what passes for acute rehabilitation after an injury. So what can we do to make things better? We can follow the examples of our predecessors in the medical, surgical, rehabilitation, disability rights, and independent living movements who built something great out of nothing. And we can use today's tools and get all hands on deck to create a model that works for everyone and can last a lifetime. We owe it to the next generation, and we have powerful role models to follow. We have about 90 minutes today. First, I'm going to give a brief history lesson introducing some of the pioneers who discovered what it takes to stay healthy after SCI, and then work together with consumers to combine the best features of the medical and the rehabilitation models. Some of this work was done right here in Boston, and Dr. Master is one of those pioneers. Next, he will describe the original Boston's Community Medical Group and what made it work. He'll talk about a new practice model that we've affectionately dubbed BCMG 2.0. We'll use the last portion of our time for Q&A to get your feedback on what you would need most for a good life after SCI. The discovery of antibiotics provided a means to fight deadly infection. The power to fight infections allowed people to survive for longer than a few weeks after catastrophic injuries, and their populations grew. Survivors of the polio epidemic and World War II formed a large cohort of people who had to learn to live long-term with previously deadly conditions. So new fields of medicine emerged to fill the need. Field hospitals pioneered some life-saving techniques. Emergency rooms and intensive care units that didn't exist before were created to provide care in the initial phases. The second phase protocols were developed in parallel in the United States and in the UK. Medical and surgical units modeled after the Stoke Mandeville, Warm Springs, and Boston City Hospital developed methods to address altered breathing, altered waste elimination, and altered movement. They also enlisted patients and families to educate and help each other. These groundbreaking places developed full care protocols to manage paralyzing conditions and taught the protocols to patients, families, nurses, therapists, and doctors. The new field of physical medicine and rehabilitation emerged to manage the convalescent phase and later life in the community. Physiatry used exercise as therapy and emphasized function and wellness. For the time, this was revolutionary. And here in Boston, Dr. Murray Freed was a direct student of Dr. Monroe. Here are a few of the pioneers who built something out of nothing. They combined their life experiences, intelligence, work ethic, and creativity to connect with like-minded people in the community and create a brain trust team that changed SCI care. FDR's relationships with staff and peers at Warm Springs provided him with a unique perspective that contributed to the war effort, how to leverage experience and available tools to make the best of a bad situation. Sir Ludwig Gutmann in the UK and Dr. Donald Monroe in the US worked with new SCI survivors and identified care protocols to manage paralyzing conditions. Staff, patients, family, and the next generation of doctors and nurses all became SCI experts under their tutelage. The next generation refined the protocols and integrated new advances like critical care, multidisciplinary team building, and patient education and engagement. They needed a consistent platform to identify the protocols, evaluate outcomes, and share information. So they created the original Model Systems using federal grant money. Model Systems offered lifetime care with yearly follow-up, including direct communication with PCPs, primary care providers in the community. And this proved to be so successful that there are now new model systems that exist for burns and traumatic brain injury. Rehab care began in the field at the accident scene using advances like the EMS system of advanced life support and CMed phones that connected first responders with emergency room physicians for real-time consultation. This set the stage for seamless integration of medical care from the accident scene through acute care. PM&R physicians consulted in the emergency room and the ICU, and medical specialists joined forces to create new treatments. Collaboration continued throughout the convalescent phase and then all the way through the lifespan. Model systems were regionalized, allowing for a critical mass of similar people getting specialized care by staff who concentrated exclusively on SCI. This allowed more effective and more personalized care for people with SCI at all stages of life. Patients and staff learned to recognize red flag symptoms and how to intervene early. They worked with the people in the independent living movement to set up accessible housing and PCA care. After discharge, people returned to their communities, but had access to yearly follow-up, specialized outpatient clinics, and most importantly, a phone hotline staffed by experienced SCI nurses. Thank you. Physical medicine and rehabilitation combine the problem-solving mindset of engineering with the art and science of medicine, emphasizing multidisciplinary teams that included all stakeholders. Patients were respected, learned what they needed to know, and took charge of their health. Technology was used sparingly. Adaptive equipment included low-tech items like riding splints and built-up utensils, as well as high-tech solutions like power wheelchairs and environmental control units. As people learned how to take care of themselves, they joined the healthcare team, taught the newbies, facilitated community reentry, and developed innovations like lightweight sports wheelchairs and United Spinal. Our job was to educate, explore, and sort through the treatment options, and then be available in the future to advise and to help advocate. The infrastructure and programs piloted here are still in use today. During the same time period, the civil rights movement brought tremendous social change. Women, people of color, LGBTQ, and people with disabilities were finding their voices and working together, forming true communities and telling their stories. They advocated for accessible housing and personal care attendants. They led protests, championed legislation, and truly changed the world. 1973 to 2005 constituted the golden age of medicine, where there was an optimal mix of old school medicine, new technologies, and emerging civil rights awareness. We concentrated on the primacy of the doctor-patient relationship, honest communication, and treating the whole person. Medical teaching stressed history taking, physical examination skills, and formulating assessments and plans by problem. Notes were concise but thorough and designed for communication. The majority of the time was spent on developing relationships and educating people about what they needed to do, when and how to do it correctly, and why they needed to do it. So what's different about SCI? What's different is that the communication among body systems is altered so that functions that are usually on an automatic pilot system need more hands-on guidance. Just like flying an airplane, instrument flying takes additional training and practice. For people with SCI, it involves being able to recognize the signals that your body is trying to send, even if the form is very different from what you might have felt before your injury. In general, you should be alert to changes in your usual level of spasticity, headaches, or changes in blood pressure. If you feel of any of these, there's a reason for it. And once we identify the trigger, it can often be reversed and the symptoms will go away. The idea of the model systems was to teach the person with the SCI everything they needed to know so that they could explain it to someone without a medical background and advocate for themselves. It was really education by immersion. Everybody was there for the same reason. The staff, any guest speakers, fellow patients, and families all lived and breathed SCI all the time. Everybody had something to share and everybody had something to learn. It was like combining a college, a hospital, and a boot camp. All the protocols centered around SCI wellness, and all the disciplines came to the unit to see their patients as consultants. PM&R was the attending of record. Even after the initial rehab stay, anyone with an SCI who needed to be back in the hospital for any reason was housed on the SCI unit. This helped reduce the incidence of pressure sores and infections on other areas of the hospital, and it also brought people with SCI together. They were able to see that there was life after SCI. Unit graduates returned to lead wheelchair mobility classes and visit newly injured people to act as living proof that there really is life after SCI. The rehab team was involved in acute medical management and followed their patients in the ICU prior to admission. The team was also integrated with home care services, equipment specialists, community primary care teams, and community reentry programs. Behavioral health and emotional support followed everybody. As discharge neared, people went on weekend passes to troubleshoot prior to discharge. Rehab services provided a bridge and a link between pre and post-injury life, acting as a resource and support for patients and their families. All the disciplines worked together to help meet patient and family goals. Necessary equipment was ordered in advance in consultation with the equipment experts, and it was a point of pride to provide for all medical needs. There were few, if any, deaths, and most people went directly home. Many of the early SCI survivors passed their knowledge on to others, formally and informally. This has become a tradition and allows people with SCI to really understand their bodies, communicate effectively with their caregivers and medical team, and to stay healthy. The people who fought for disability rights and founded the independent living movement often became healthcare providers themselves, and they add to the body of knowledge that we use today. Because SCI is rare compared to diabetes and high blood pressure, most doctors and nurses have never seen it unless they trained at a program associated with a model system site. Model systems provided a critical mass and consistent routines. Everybody on the unit lived all SCI all the time and could learn to improvise when necessary. They still exist today, but they work on an accelerated time clock, and not everyone with an SCI has access to one. This kind of care is idealized and expensive, but well worth discussing as it provides a model that we can aspire to, especially as telehealth services grow. Today, our healthcare system focuses on the health of large populations rather than single individuals. And people who battle rare diseases all too often fall through the cracks. The key to wellness with a chronic condition is knowing what to expect from it over the course of a lifetime. And the best way to accomplish it is by preventing the problems, if possible, or at least to catch them at an early stage so you can manage them. And this approach applies to all of us. We are aiming to recreate a model medical practice to help you stay well and live your best lives. So how do you allocate scarce resources equitably? If you can't save everybody, who do you save first? The goal is to treat the greatest number of people using the smallest quantity of resources and at least attempting to be fair. How to use the tool, it's also about how to use the tools we have to their best advantage and providing care and support to people away from the hospital setting. And that's where we need some more work. SCI is the proverbial low incidence, high intensity condition. Knowing the pitfalls and building around them has worked very well, but requires a long-term outlook and upfront investment of resources. Given that SCI is rare, how can we pull together those resources and still manage costs? Standardization is one tool that's being used pretty heavily. The sad truth is that these resources are limited and that somebody needs to decide what gets funded and what doesn't. Today's system concentrates on accountability and managing common and time-limited conditions using standardized treatments. Data collection requires expensive hardware and software. High-tech treatments can cost millions, benefiting only a small number of people. And that's why the industry has moved away from the individual patient and zeroes in on specific populations. And it also explains the emphasis on evidence and cost control. Conditions like asthma, high blood pressure, kidney disease, and heart failure affect millions of people and consume the lion's share of healthcare resources. These conditions present an opportunity to greatly reduce healthcare costs so that the money can be used for other worthy purposes. Standardization protects against dangerous or ineffective treatments, but one size does not fit all. Where does SCI fit in with all this? Getting the right equipment and the right supplies at the right time is the key. The kind of care we've been talking about works really well, but it doesn't affect huge numbers of Americans that need care. And unless somebody really understands what SCI means, it might seem foolhardy and wasteful to spend $50,000 for a custom wheelchair for one person when an off-the-shelf power scooter costs about 1/10 of that online. However, that same chair will prevent infections, pressure ulcers, pain severe enough to drive someone to use addictive medications, and a host of other miserable and costly complications. For an individual, that chair can mean the difference between life and death. If the chair fits properly and is well maintained, that chair may last for years and prevent an awful lot of ER and hospital visits. From a numbers point of view, spending $50,000 over 10 years to prevent millions of dollars of hospital costs seems like a no-brainer. But if you're only looking short-term, it really looks foolish. And that's really the difference between short-term costs and long-term investments. On November 2nd, United Spinal Association featured a really interesting presentation by Nick Struthers from the Northern California chapter and Natalie Barnhart from the Western New York chapter. They reviewed average lengths of stay at different times in a model system setting and issued a call to action. Their findings included that in 1988, the stay after spinal cord injury and acute rehab lasted somewhere between 3 and 9 months with an average of 6. By 2006, that length of stay was down to 70 days. And in 2016, That was down to 16 days. That's a couple of days over 2 weeks. And that is not enough time to absorb the impact of a catastrophic injury and learn what a person needs to know to stay healthy. So some of the unintended consequences of our changes in the healthcare system include the fact that most newly injured people have little, if any, access to rehab at all. Any rehab they do get is in a skilled nursing facility. And there are not enough staff members, and the staff members that there are don't have the training necessarily to recognize problems early. There's a very high healthcare staff turnover, inadequate access to equipment and supplies, and that causes a very poor transition back to family and community, and can sap motivation and lead not only to rehospitalization, but also to depression. It's really hard to act if you don't know what to do. So if a new spinal cord injury patient doesn't know what's needed or how to get it, as lengths of stays, initial hospital stays decrease, morbidity, mortality, and complications increase, which makes the status quo unacceptable. But maybe there are some things that we can do. Some of this has been done before, and there are some things that we can do that are already here. The second half of the presentation focused on the Motion Project in Buffalo, New York, that Natalie Bonhart started. This is an adapted gym with trainers that are familiar with SCI, and it offers a social outlet as well as a place to exercise. It's growing. It's similar to Project Walk, Journey Forward. I mean, we've seen these before, but this one was opened during the COVID crisis and is growing. So what we really need is a multi-pronged approach. We need role models and a can-do spirit. We need education, maybe core curriculum to cope with SCI, geared to both consumers and providers, and that can be delivered remotely. Advocacy, explaining to policymakers and to payers why we need to change course. Last but not least, fundraising, private, government, and nonprofit. We know we need home-based care with appropriate supports. We need accessible housing, food, equipment, proper supplies, PCAs to help with ADLs, teams of experts that people can call on, peer mentors and people who have been there, and technology to fill some of the gaps and scale up the model so that it includes more people. Passing down what we have learned to the next generation so they feel empowered to innovate. That sounds like BCMG, where I worked starting in 1998, where all the clinical staff learned about the secondary complications of not just SCI, but different paralytic conditions and how to prevent them. Care was done through home and community-based, using the hospitals sparingly, if at all. And they had a group of like-minded specialists, as well as a consumer board, to provide services and feedback. Probably the most important thing, clinicians had delegated authority. They had the ability to decide what treatment, what piece of equipment, what medicine was really medically necessary without having to play Mother May I with CMS or other insurers. The COVID pandemic provided a small silver lining, and that's what we're doing right now. The wide use of Zoom, Google Meet, and other video conferencing formats. Peer support groups that used to meet in person had trouble with attendance because access to transportation was limited and people couldn't get there. But now, United Spinal in Greater Boston has at least 11 groups that I know of that all meet weekly. And they also have this educational format, and they're still growing. Well, let's go back to the future. where the possibilities are endless. Let's combine the team approach and taking people with multiple chronic conditions as a separate population. It makes sense and it stood the test of time. We can use virtual formats to get around architectural and transportation barriers. We already know some of what works, so let's put our heads together and figure out the rest. Thank you. Sure. Some of the resources, Heidi's going to have the slide decks, so don't worry about writing it all down.
Yes, I will send this out to all the participants. Thank you, Susan.
Thank you.
Susan, before we just make the switch to Dr. Master, did anybody have, I can't see everybody on the screen, but were there any questions that anybody had? I'm going to read Abby's question here. I can't see everyone on the screen at the moment, but Abby's asking, and Abby, do you want to unmute yourself and just ask the question?
Sure, and it's
Abby.
kind of a wordy one. I'm sorry about that. I'm just thinking back to a similar societal trend that I was more familiar with back in the day, which is the deinstitutionalization of folks with mental illness, where the presumption was, you know, they deserve better than to be trapped in institutions. Somehow we'll have community housing and appropriate supports for them. But I see parallels here. You can't discharge people without accessible housing. You can't presume that they'll continue to be well without support services like PCAs. And I'm just wondering, is there anything that the medical establishment, as it were, or agencies or insurance companies have learned about what happened with that societal shift that pertains here?
Funny you should ask. Maybe we should hold that question till after Dr. Master's presentation. There absolutely are parallels. The whole problem was they closed the inpatient institutions before any community supports were built at all. And if we make the same mistake, it won't end well either. So hopefully we can, I think there are a lot of people thinking about how to do this. So
great. No, I'll listen and maybe we'll discuss it later.
thank you.
Wonderful. Thank you. Thank you, Abby. Great question. So I'm going to, Dr. Master is going to be speaking now.
Yes.
Great. So I'm going to just go ahead and spotlight you and you can get started. Hi.
Thank you very much. And Sue, that was a wonderful presentation. And what I'm going to describe is what evolved starting more in the community, but really internalizing a lot of the same values and goals that Sue described. And I think I really want to start with the origins of Boston Community Medical Group, which really was more than just a revolution in practices and models of care for people with spinal cord injury and other involved disabilities, but also was a revolution in values and in financing, because when you cannot get delegated authority that Sue mentioned and is so critical without changes in financing. I really do want to say that Sue was really a totally invaluable part of this practice for many, many, many years. It really was a hybrid between those of us who came from the internal medicine or family medicine background, and then those who came from the rehabilitation background. And that when we talk about interdisciplinary teams, I think was modeled beautifully there. And I can speak for myself and many other clinicians that did come from the more medical background, that we owe Sue Bergman, and in my case also Paul Corcoran, and then obviously Murray Freed, who was a wellspring for all of us, just so much appreciation for how it enlarged our vision, which was quite narrow, by the way, compared to the rehabilitation vision. So I just want to acknowledge the extraordinary contributions that Sue Bergman has made over the years. So let's turn the clock back to the 1970s and 80s and talk about the context, the origin and the history of Boston Community Medical Group. And that historical context is what you see here. There was a civil rights revolution that was occurring, in many ways patterned after the revolution that was occurring in the racial sphere, starting with the Civil Rights Act of 1974. And there were a number of acts in terms of disability, but the Rehabilitation Act of 1973 was major. And there's one not mentioned here in 1974, the Medicaid, which was a relatively small program nationally and actually marginalized for moms and kids on welfare for the most part, amended that to create a program for disability. And in 1974 did that, and also made people eligible for SSI, income maintenance, living in the community, and that started the movement of closing down the institutions that were really with the warehousing of so many people in violation of their civil rights over many, many decades. What we're talking about here in that period of time is that Massachusetts was an epicenter for this civil rights revolution. And that epicenter really centered on two organizations. One was Boston Center for Independent Living, which was the second CIL in the United States. There was a limited CIL. Ed Roberts at Berkeley was a model for that. But what Boston Center for Independent Living did was they were really the first in the nation to engage the state in policy advocacy. And in 1974, maybe the most significant expansion in benefit design of any payer in the United States, private, Medicare, Medicaid, and any payer or financer of medical care in the world, including the European systems, was the establishment for the first time anywhere of a PCA benefit. One could say, I'm going to get people home into housing and out of institutions, but unless you had that PCA for people with very involved disabilities, with extensive ADL dependencies, that was just verbiage. The PCA benefit really was the revolutionary start, and that started here in Massachusetts. It also led to Massachusetts becoming a migration magnet. And I remember this, people came to Massachusetts from all over the country. That was their one way out of institutions. And we remember in the 70s and earlier, if someone had a spinal cord injury, like a Charlie Carr, who was a founder of BCIL, they went from whatever public education program they had. In the case of Charlie, he was in high school, to a state school, in his case, the Mass Hospital School, and of course it was a group of people like that started along with Charlie's BCIL and started to really hone in on what the policies were to live independently. And at the top of that list was the PCA benefit. And that began in 1974 as the first Medicaid program in the country to do that. Then if we can, that's kind of this very exciting context that was happening. In the early 1980s, I connected along with my late wife, Marie Felton, with clients of BCIL And there was an article published in the Boston Globe. Could I, Sue, have the next slide? And we'll just move off this busy slide into the.
Working on it. There you go.
Yeah. There was an article published in the Boston Globe that highlighted a model that we were involved in the 1970s and early 80s for frail homebound elders in the inner city. The Globe wrote a piece on that. BCIL clientele read it, and they came up to our small practice in inner city Jamaica Plain. Actually, I can tell you it was a hot summer night. It was about 100 degrees out, and 5 people came up in their motorized wheelchairs, and 2 of them had a 6-pack of beer, which was very, very, very appreciated. And that was my first introduction with these pioneers there. And what we heard, and I took notes, and I have it in a yellow notepad, and I wanted to share it. What we heard from these the independent living pioneers were the following. All our goals for independence and autonomy are now being subverted by the medical care that we received. We are continuously infantilized. We know our bodies better than anyone, but no one listens to us. And this was the arrogance of the medical establishment that Sue and I and others became very familiar with. A comment, last year I had to be reinstitutionalized for 3 months for a deep pressure sore that needed a flap procedure. Why? I couldn't get a timely seating evaluation. And it was interesting, the word reinstitutionalized, because people. Reinstitutionalized because so many people had direct and traumatic experience with being institutionalized at that period of time. I'm sick of emergency rooms and hospitals. I always come out worse than I went in. When I tell my doctor I believe I'm brewing another UTI, I'm instructed to come to the office next week in an appointment schedule. And I will need that hospital before then, almost certainly. Those were, it was stark, and it was the contrast between the aspirations of independent living, human rights liberation and civil rights liberation, and where the medical care system was culturally and by values. Could I have the next slide? So when that article piqued the interest of BCIL clients, it was a very simple evening conversation. We said, why don't you design with us what an optimal primary care model looks like? And that design led to Boston Community Medical Group. That evolved into Commonwealth Community Care and CCA, and I'll give some of the history, and it's now evolving further into where we're going in the next, this past year and in the next few months. Can I have the next slide, Sue? Mm-hmm. So that model really turned out to be a number of changes that the clients and really said needed to happen. And Sue has already alluded to some of these. And so what were those changes? Well, first of all, you had, most people they had to fit and be shoehorned into the systems of care for the general populations in hospital systems or ambulatory medical practices. That was pretty difficult for a lot of people that had no choice but the ride. Then as now, very unreliable in terms of time to get to practices, but also you needed a 24, 48-hour window before you could have an appointment. And as everybody on this call knows, there's very low thresholds to complications. Things happen fast. You don't want to wait in many cases for 2-3 days to get in and fit into an appointment slot. So the first change was home visiting with interdisciplinary care teams, and the BCMG experience had that with nurse practitioners, physicians, physical therapists, social workers, and as we'll talk about further down, integrated behavioral health. And part of that was recognizing that you needed to basically respond and respond quickly to a significant number of problems. And there was no way to have that response if you had to move somebody from their home in the next hour or two to a medical evaluation. The only place you could do that, the only way you could do that is an ambulance and an emergency room. And there obviously needed to be an alternative to that. The second is what Sue alluded to, and we feel is absolutely there. You had anonymous prior approval processes and benefit management from insurance companies in the one-size-fits-all benefit management. And what was really needed, and this was at the top of the list, individualized care plans and resource allocations, what are the number of hours of PCAs that are needed, specialized equipment, air mattresses, DME as a clinical service, not DME as a benefit to be managed by an insurance company, and therefore delegated authority. And the third is that you want to have that emergency response situation and a capability. Without that, the autonomy and independence is really subverted, because you have no choice but, in many cases, the ambulance in the emergency room, or distant telephone management, which can be very, very suboptimal. So that was replaced by the interdisciplinary teams of advanced practice clinicians. There were a lot of people that had social isolation and difficulty managing the transition, and clearly that was exemplified in the catastrophic change in the lives of people with spinal cord injury. But there were also the issues of how do I live independently with other causes of disability, degenerative neurological conditions, for example. And so the idea of peer counseling in the spirit of the empowerment and independent living it really needs to be a part of this team. A lot of behavioral health and mental health issues are concurrent. People underwent, in the case of spinal cord injury, just profound trauma, not just physical trauma, but emotional trauma. And so the idea of integrated behavioral health clinician assessment in the practice, and this is an alternative, again, to going to an emergency room, being evaluated, and waiting for a very, very rare bed in a mental health facility that can also accommodate disability. And the issue for so many people also was going it alone, and you needed an alternative to that, and therefore a reliable continuity medical response system 24/7. And what we're really talking about was personalization, and really, and that was actually one of the most inspiring experiences over many decades. The relationships became totally two-way, first name, bilaterally, and even went beyond that. Mary Glover, who was the iconic nurse practitioner leader for many years at BCMG, married her first patient in the 1980s, and there were other stories, maybe not quite that kind of intimate in relationship, but the relationships were long and deeply meaningful to both the clinicians and the individuals who were receiving care. So this is no surprise to anybody, but yet it didn't exist. And the financing for that didn't exist. And so the innovation of financing, and I'll show you some data a little bit later, came with working once again with our Massachusetts Medicaid program. And again, kudos, we live in a state where we have had one of the most innovative and forward-looking Medicaid programs, if not the most, in the United States over many, many, many decades. Could I have the next slide, Sue?
Mm-hmm.
let me just throw one example and one among many. And this is not, we changed the name to Bill T. In the individual, he was 56 when he died around 2014, 2015. But we met Bill back in the mid 80s, approximately 30 years earlier, with a high-level spinal cord injury, quadriplegia, neurogenic bladder, recurrent pressure sores. He was married, lived with his wife, had a daughter. For many years, he had inconsistent PCA support, and it was really being managed. You know, the good news is you had a lot of support, but it was inconsistent in terms of hours and redeterminations, et cetera, from Massachusetts Medicaid. He had lifelong asthma and really significant medical issues prior to his injury. And of course, then you take the weakness of spinal cord injury progressing over many years, and there were significant problems. When we first met him, he was receiving care from multiple specialists in 2 hospital systems, not communicating with each other. It was before electronic medical records, and even with that, they didn't communicate later. And the emergency room was really all he had. There really was no primary care team. And clearly, I think he was coming in as the model spinal cord injury programs were being phased out. And in the 18 months before joining BCMG, he had 6 hospitalizations. 2 were for rescue, prolonged intensive care stays with sepsis, and then 1 long rehab stay. And what happened with the interdisciplinary team models and the responsive changes and the individualized care plans were that he then underwent approximately 28 years of independence, became a leader in the management and operations of BCIL, and had raised a family with few, if any, hospitalizations. Count them on one hand over 28 years. And then what eventually happened was after 30 years, his underlying respiratory condition and the high-level spinal cord injury started to he started to go into progressive respiratory failure, but had an extraordinarily productive life. At least when he was coming to us, he seemed to be on the final turn, given just a recurrent pattern of hospitalizations before that. Could I have the next slide? All right, this is a busy slide, and I'm going to try to explain this in numbers, because this was at Boston Community Medical Group. What we did was, the second part was the revolution in financing, and created with Massachusetts Medicaid the first capitation payment. In other words, no longer just fee for service and mother may I supplications to a payer, but actually getting responsibility over the total cost of care for people with involved disabilities, so that we could make those decisions about, we, along with the individual who had the disability and injury, could make decisions over what was the appropriate care plan to promote autonomy, independence, and manage health. And so we're going to look at, but before it changed the financing, which began in 1992 at Boston Community Medical Group with Medicaid. If you look at the top line, 1990 and 1991, over on the left, was what Medicaid in a paid, BCMG received a payment just to cover basic primary care, but that number of $1,749 in 1990 and $2,228 in 1991 was the average total cost of care. It did not include pharmacy, and it did not include PCA, so it wasn't all in, but it was everything else in the medical sphere: doctors, hospitals, long-term care, home health, all the components of a healthcare system. And it was 2,228 in 1991. In 1992, we flipped the switch and it went to the BCMG, the capitation model, where BCMG was responsible for the expected cost of care. And they had given an amount to BCMG, or to be managed by BCMG, of something in the range of $2,100 based on 1991 experience for people with involved disabilities. And if we look out 92 through 96, a very substantial diminution in care cost, $1,500, $1,200, but not 2,000, not 1,700. Okay, very significant in total cost. And the question is, where did that come from? If we go back to 1990 and 1991, of the amount of spend, over 50% of the spend went for hospital care. In other words, people were back and forth to the hospital. It was $854 per person per month, $1,233 in 1991 per person per month. And then if we go to 92, 3, 4, 5, and 6, you see a very dramatic reduction in per person per month expenditures for missed opportunities to manage complications. That's really what 90% plus of the hospitalizations were, for the UTIs, the skin breakdown, the respiratory complications, metabolic complications. And taking that down absolutely significantly, not marginally, but significantly for those 5 years. There were also significant increases in the other parts of the system. The increases in primary care, increases in DME and supplies, and I don't have a chart there, but PCAs, primary care, and DME turned out to be the most expensive components of a care model, but it was more than off of the BCMG care model, but more than offset by the reduced hospitalizations. Could I have the next slide, Sue?
Mhm.
So that was Boston Community Medical Group. We moved it in our trajectory. It became Commonwealth Community Care, and as some know, Commonwealth Care Alliance was created as a nonprofit entity to really scale all of this work. And that was for Medicaid and dual eligibles, seniors and people with disabilities. And that was a lot of the work we did in the 2000s. I retired there at the end of 2015. And one of the reasons why you see the arrow going up, and we're provisionally calling it Innovation Care Alliance, but we don't know if that's the final name here, is that we really want to now move to BCMG 2.0, really embodying all of these other principles. And as Sue mentioned, moving into the 21st century, we now have revolutions in telemedicine and communication, in biometric monitoring, and other work that has been done. For example, putting paramedics into the practice, where instead of bringing an extraordinarily well-trained paramedic to take somebody out to an emergency room who's having fever or shortness of breath, they along with physician consultation would manage, would evaluate somebody in the home and start the process of keeping somebody at home, substituting for hospital care, which we're seeing as the next 21st century kind of evolution and innovation that's near there. And CCA in current leadership has made a strategic decision to move away from serving and focusing on the, as Sue mentioned, smaller numbers of higher need populations, and building a large national program for more typical Medicare Advantage. And thus, we're feeling the need to actually continue this work over 30 or 40 years that it's been underway in the recreation of Boston Community Medical Group 2.0, and hoping to go live in the first quarter of 2022. And but it starts with all of those same principles, all of those same values. It's a nonprofit organization. We'll have a consumer board, all the things that we've learned before. But I wanted to give this background. And could I have the next slide, Sue?
Mm-hmm.
And then, so we're coming up to questions, comments, and suggestions. This is why we wanted to leave a lot of time. And I guess the final slide, Sue, and then just this is if you want to stay with us, Sue or myself, with us. Here are our emails.
Wait a minute. There's
Did
an
I get
error.
you right? Did I get you right?
Yeah, no, there's another B. There's another Susan Bergman. So it has to be Susan B. Bergman.
All right. I'm sorry. I didn't see that. I looked at that. So put in that B. Can we?
I don't know if I can.
You probably can, but all right. So Susan, 2 B's. I didn't see that.
Yes, 2 B's. Really important. Otherwise, it'll go through, but I have no idea who this other person is.
I don't know. So it's Susan. So to be or not to be, right here. We'll get the 2 B's in there. And so I just wanted to stop there.
You're on my presentation.
Yeah.
Thank you.
Yeah, and I
will make sure that the correct emails, I will send an email to all of our participants today, and I will make sure that we have the correct contact.
Yeah. I think we really do want to stay in close touch, and so we'll stop there and open it up for discussion.
Okay, I'm just going to cancel the spotlight video so we can see everybody on the screen here. So yeah, anybody has any questions? I do believe that Abby had, Abby says that was super interesting. That was really fascinating, really enjoyable to listen to. And thank you so much, Dr. Bergman and Dr. Master. Abby, did you want to, you had put something here in the chat.
Yeah, it's more of a comment just to sort of, I'm sure you guys know about it, but there's this tiny there's something going on that's like a tiny aspect of what you want to do. It's the home hospital program that Brigham and Women's runs, where you report to the emergency room for a UTI or whatever, and they say, we think we can treat you at home. So they send nurses. They can even give you IV antibiotics if you need it at home. They just basically do on an outpatient basis in your home what they would have done overnight in the hospital. And it really worked excellently for my son. And it just seemed to save so much grief and potential complications versus being in the hospital.
Yeah, no, I'm very familiar with that program, and I know the people that run it, and it is, for the right people, it's positive. I think that's where this world is going, I think, to see if we can move these to home. What this is thinking about is we're going further back upstream and saying,
yes,
we want to identify people in advance that are at risk for these recurrent hospitalizations, as opposed to learning about them just when they land in the emergency room. But I do want to say that's a very important innovation that's happening at the Brigham, and it points out what I think where some of the opportunities are. And I think the way we would want to design it is really have that long relationship with people that are at risk of those hospitalizations. But so yes, it's good to hear the validation from others that this idea is there. We are that's where we want to integrate paramedics into this too, but that's another conversation.
I think integrating, the support groups into it and the educational pieces into it that United Spinal is already doing is also an important piece. I mean, after you've been living with a spinal cord injury for 30 years, you probably have a pretty good idea when you're getting the UTI. So, I think that you can intervene a lot earlier in the process. And, the misery and the costs further. But you have to be aware that it's going to cost money up front.
If folks want to, if you want to put yourselves back on camera, it's great to see faces and easier to see if anybody has a question that they'd like to ask. No pressure.
Hi, this is
question.
Oops, sorry.
Okay, Joe and then Jane.
Okay. Do you utilize respiratory therapists at all?
Certainly in the model systems we did, and at one, didn't we have a respiratory therapist at BCMG? I thought we did.
Yeah,
We
we
Charlie
did.
O'Donnell.
Yep, yeah, we did, or we had him as a consultant.
Yep.
There were on the regular team were PT and OT. Certainly, seating was a capability of doing that. Evaluations. Respiratory therapy was a consult. Yeah,
Yes.
You're closer to this than I am now. I mean, that's another example of our interdisciplinary approach.
It's actually gotten harder to access folks
Yeah.
in Medicare.
Yeah, yeah. I didn't know if in home care, if part of that was a therapist coming into the home to help out with therapy right at home.
I don't. Yeah. What did Sue? Do you in the original program?
Sometimes, I mean, and we made more than one visit where the nurse practitioner, the primary care doc, the me, physical therapy, occupational therapy, usually not respiratory, would go and evaluate somebody to see, what we needed to do. I think some of that is timing because there was a lot more time devoted to it earlier when people were in the hospital. I think that would definitely have to be added to this model.
But the
trouble is that eventually, if you're in the home, there's only a limited amount of equipment that you can't bring an FES bike into somebody's home, and put it in your car and bring it to somebody's apartment. So I think that what they often did was they would train the PCAs. They would certainly train the person and they'd say, okay, this is how you teach somebody to do range of motion exercises. And
Just a thought.
Yeah, no, it's an important thought because we're at this. We're really doing. We're trying to not just recreate everything that was done decades ago, but what are the 21st century enhancements? And we've already landed on paramedics, but so it's that this is exactly the process that informed the original BCMG. People that had lived experience saying, what about this? Why are we not having that? So we should talk about this. And maybe that goes into the design and develop criteria for that.
So hello, it's Jane Werbicki. I work with the United Spinal Association Resource Center. And in my role as a nurse there, I hear from people all over the country who are affected by this fragmented care situation we're in now. And so I really appreciated your presentation and hearing about where you're going with BCMG 2.0. And so excited to see where that goes. But I just wondered, as a community of advocates here, how we can best support your efforts.
I can start and Sue can add or other way. I think there's a lot of wisdom that both the clinicians caring for people with spinal cord injury have, and certainly people and their families themselves. So we're actually trying to make this design process an open process. This, by the way, this is nonprofit, open source. Nothing is proprietary here. So so there's a lot of lived experience that can help inform this. And that was a winning formula back decades ago. And we're just beginning to do that. And talking to various advocacy groups, obviously back to our colleagues at BCIL, DAR, DPC, but would like to stay in touch around this design and what does this look like. That determines the financing package that we're trying to negotiate. So yes.
Yeah, and I can be a bridge through United Spinal. I think United Spinal is probably the one organization that really has the reach and the organization and support to actually make this happen. And, you know, I'm now retired and I'm volunteering at United Spinal, and Jane and I know each other well. Heidi and David.
We're connected, and you're
connected.
Yeah. Okay.
I'm happy to act as a bridge.
That's the answer to the question, Jane.
Great. Thank you. I will definitely reach out.
Were there any other questions? I was trying to see if there was something in the chat. ED, I know there's a lot of different acronyms. Yeah, ED is Emergency Department. I usually call it the ER, but I guess it's, ED is the.
Sorry about that. It's inside baseball. I'll spell it out next time.
That's fine. I was also, I had been like, I had to think again what BCMG, Boston Community Medical Group.
Yeah, exactly.
We have a question. Sorry, did someone else have?
Ed asked if there's in-home training available for family members who serve as the primary PCA. That used to be a very big part of what we did. I'm not sure if it has been appropriately replaced in this model. I have a feeling not, and that's something that really is needed.
Yeah. Way back in the day, families were not allowed to be PCAs. That's obviously changed, and that's good.
Really? I mean, I wonder. I mean, Dr. Fried used to say that you wanted the families to know what to do if they had to do it, but that to have your family doing some of this care affected the relationship.
Well,
and,
but the examples I'm thinking of may not necessarily be the spouse, but it could be another family member. I'm thinking of a family where there's a granddaughter that is going to nursing school, and actually the family wanted. That's just one example.
I think more of it should be a choice rather than kind of what everybody has to do because they can't afford to pay another person to act as a PCA, and they are over asset to qualify for Medicaid.
But they're paid PCAs as family members. That's what CCA did.
That's what CCA did, but for people who don't have CCA.
Yeah.
I think many people feel as though that they choose to have a family member as a PCA because it's more reliable. If they're needing to rely on the hours that they're sometimes seemingly arbitrarily given, and not able to rely on PCAs to be there when they're supposed to be there, they wouldn't have to rely on that. But Mary, go ahead.
Hi, excellent presentation. Thank you very much. I love finding out history of things or why things are the way they are now or why they're not now. My question is I just forgot it. I had two questions, so I'll ask the second one first then. Is that when you're designing this, are you just talking Boston, or are you thinking it's going to, grow to the state, to the national level? And what's the next step then? I mean, like, obviously this is, great to know now. I mean, what do you need us to do? You want us to talk to our representatives? Do you want us to march on the state house and run it over and make them do what we want them to do? I mean, what do you want us to do? Yes.
in this initial, at least we're thinking this is going to be Eastern Massachusetts. We don't know the exact, but it's Greater Boston, inside 128, inside maybe 495, you know, but not the world. And we don't need it. And for the first year, several hundred, but not thousands. We've got to, it's got to be, and we're not looking for we actually do very, very well with Mass Health and policymakers. What we're really looking for is a contract with a payer in this space that is not going to run and hide when we say we need to have delegated authority over the allocation of DME and PCAs and things like that, and get that kind of support. And now there are discussions underway. I'm not able to talk about which payer, but we're hopeful that in the first quarter of 20, we will get that contract. And so it would, if it is. But I don't think we need advocacy. I think we're right, because that's not with the state. There may be some other policy stuff with the state that advocacy is needed. So I think it would really be helping with the design idea, or there's just a lot of wisdom here and staying together as this evolves. That that would be my hope.
What do you think about contracting at the federal level? I mean, as I understand it, that's been the major problem since the beginning, is that at the federal level, things are standardized. Yeah. And so that you end up with this patchwork where, depending on what your insurance is, just like the PCAs, if you don't qualify for Mass Health, let's say you have Blue Cross, and then you lose your job and you can't pay for your premiums, or they decide you're too expensive and they get rid of you, but you don't qualify for Mass Health, you get, a couple of months worth of physical therapy or nursing, and then that's it. You have to pay privately. So that's a huge issue.
There may be some hope in that area. This is for people that have Medicare. They're Medicare eligible, but they're not Mass Health eligible, because we have the duals that you can put that together.
Right.
But the current group now is working on, and this would be beginning 2023, so it's a year off. It's called High Need Medicare Contract, Direct Medicare Contract. So a group like this could contract with Medicare for not the whole. You're not an insurance company, but you can contract to fund on a global payment basis, a fixed payment every month for a basket of services like the primary care teams and responsibility for medical equipment and now PCAs are not a Medicare benefit. That raises another whole issue that would not be solved, but we could be only a few months away from a new contracting option, and but that would not be in the first part of 2022, but it's scheduled for the end of 2022 or early 20. So that's part of the work. What's out there that we can try to change, but there's been a lot of thought. What you said is widely recognized as a real problem, and particularly for high need populations, there needs to be another financing vehicle for Medicare.
Well, that might be where advocacy and writing and fundraising. You have the Christopher Reeve Foundation, you have the Travis Roy Foundation, you've got United Spinal, that we can really look at some of this other stuff that wouldn't necessarily fall under the same umbrella as BCMG, but that people need, and it could be done under the auspices of a different organization. Do you see what I mean?
I think all of that is correct, is right. Yeah.
Great. We have a question from Joe and then Asa.
Thanks for the presentation, and my apologies for being late. That darn time zone goofed me up again. But anyway, the question I'd have is, have you published or do you consider publish your findings and or your model?
We did extensively in the 1990s. We have a whole bibliography from all the BCMG experience, and we could send that out. There were a number of articles, and some of that data came out of one article that we had. So one of the things we could do with Heidi is send out a bibliography, and it sounds like that really positively validated the both the cost and the care aspects of this model. And by the way, just to say it again, it was really the process of developing it was, and years ago, was with BCIL clients. So we were that principle, and then a consumer board that was integrated with it really was a critical piece in this design.
Yeah, I think another
so we can get you bibliography from back then.
Yeah. We may need to take this show on the road a little bit and give presentations like this. It doesn't have to be you personally, because you're stretched in a million different directions, but this is where some of the United Spinal folks could be very helpful.
Yeah.
Great. Thank you. And Joe, I have the all the slides from the presentation, so I can send those to you as well.
Okay. Thanks.
Asa, do you want to ask your question, or do you want me to read it? Well, Asa, I'll read it, and if you want to jump in, please do. Asa is asking, for quads who need full assistance with bowel and bladder routines, what home care resources are available now? In New York, I used to have an LPN through Medicaid a few hours a day. Now nearly impossible to obtain one.
That's where the big problem really comes in. Before, you could get a PCA, you could train a PCA how to do bowel care. And now if you get your aides through an agency and they're at an LPN level or higher, or certainly the home health aides are not allowed to touch catheters or do bowel care. And that's a huge need that's not being filled properly. And it's one of those things that I personally find very frustrating because it doesn't make common sense. And it's kind of put in place by people who don't understand what's going on and what's really needed.
Yeah, I couldn't agree more. And we've always used the self-directed PCA as the ideal support for that. Yes. Now, again, you need to be in a Medicaid or, and that it does that, but that has been the most successful, I think, approach.
I mean, maybe raising money to pay private aides. That's what we did from Dad.
That might be a fundraising opportunity or an advocacy opportunity, because for certain conditions, if somebody, let's say, is commercially insured with Blue Cross, at some point, it's in their interest to fund that self-directed PCAs. They don't, but they should. I mean, because and that doesn't exist yet. So that's added to a list of advocacy, I think. And
Heidi, I had trouble getting my mute off there.
That's okay.
So you're saying the situation is what it is. I'm just going to be stuck.
At the moment, I think part of the issue is there's so many problems that there's no way you can do everything at once. And I think what we all need to do and could only do together is maybe form small working groups to look at what does this really look like. And to get, I've tried a couple of times and I end up with a kind of a rambling product that, people's eyes glaze over. But, if you can look at, well, what do you need? And you just brought up a need. You need somebody to help with bowel and bladder care. Absolutely. So that means, a self-trained PCA. And what do you do if you are not wealthy enough to pay somebody privately and not poor enough to qualify for Mass Health or other Medicaid? And then I think we have to put our creative hats on and, you know, talk to the state about, well, gee, how can we, you know, supplement pay so that everybody with a spinal cord injury has access, and go to the insurance companies. This is going to be a process that is going to take a lot of work. There's no way a single person can do it, but lots of people, you know, many hands make light work.
Yeah.
So what do you suggest? I try to network with other people in my same condition? And
Have you written to your legislators?
I have, a few years ago when I was having the same issue, but they directed me to people upstate who basically gave me lists of independent contractor LPNs to call them and see if they would, you know, get into the Medicaid rolls, so I could basically almost like a CDPAP thing, but not directly a CDPAP thing, where they would work for me, but they would be an independent contractor. So they would send their payment information to New York State and have New York State pay them for the few hours for the bowel and bladder care. But a lot of times when you call these lists, the numbers don't work, or the people aren't doing the home care anymore and things like that.
So
Because from the point of view of people, sorry?
Yeah, no, I was just going to ask Asa, you're not eligible right now for Medicaid, is that correct? Is that?
Oh, no, I use Medicaid, yes.
You are Medicaid. Well, then you are, this discussion could go online, because then there should be funding for a self-directed PCA program. And
I was suggested to do that by the agency that I use for my PCA service. They said look into that, but the thing with that, what I've been avoiding with that is you have to have backup aides, and I don't really have a network of a lot of people I know who you know, do the aid servicing. So if somebody calls in sick or they have a problem with their child and they have to take off a few days, I would be stuck.
Are you working with the Independent Living Center?
Yeah.
Excuse me?
Do you work with any of the independent living centers?
No, not right now.
See, they actually could do a lot of the coordination of backup aides. It's still, you would make the decision, I want this person, not that person, and then how many hours, but you could get administrative support through a CIL.
Yes.
Maybe in your case, it's really getting you connected to the CIL in your area. You know, I don't, you know, I know some of the CIL leaders. Obviously, BCIL is the most important, but also, you know, Metro West is in the western suburbs. So maybe offline.
Because we're, Asa, you're asking really important questions, and questions that many people are struggling with. Asa is also living in New York.
Oh, okay.
Yeah, but Asa, maybe we could take this offline and follow up and see if we could get some information for you, if that's okay.
Yes.
Yeah. Okay. Great. I have all of I have your contact information, so I can be in touch with you.
Okay. Thanks.
More information. I just
Jane, do you have my phone number as well? Or?
If you want to put it in the chat to me, you can. I don't believe that I do, but
okay.
But I do have your email address. So you can email it to me, or yes.
Okay.
Jane, did you want to ask your question, Jane? And then I think we probably need to, thank you, Jane.
Yeah, Asa, I just put a link to the Centers for Independent Living in New York, their directory in the chat for you. Yes, just one question I know you mentioned previous publications about the model of BCMG, and I know I've seen those in the past, but I'm wondering if you are aware of any other similar programs across the country, or in conjunction with any of the model systems, if any other locations have similar models ongoing or efforts in these directions?
I'm not.
Uh-huh.
And again, I think it's such a huge, complicated problem that, and even we're doing this, that you kind of have to start small and figure out what does it look like? What could it look like? And then pilot it with a smaller population. And then you get the data out there and say, hey guys, this is what we did. These are the numbers. We should do this in other settings. And I think that's what we're working towards, and that's what we would need help with.
It's a discouraging answer I think I'm going to give you. There are two other entities that were like BCMG in the country. So there's only one is Independent Care Systems in New York. I think they're mainly based in Brooklyn. And the other was Community Health Partnership, a remarkable organization in central rural Wisconsin, Eau Claire, Wisconsin, that had Medicare and Medicaid dollars. And they would send out interdisciplinary teams into the home that sometimes the driving time might be 85 miles, which actually could be more efficient than trying to go from East Boston to South Dorchester in rush hour. But both those the program in Wisconsin was killed by Scott Walker, a reactionary governor of Wisconsin. It was too tied to Obamacare, and they killed it on the state side. And ICS is running into all kinds of problems right now. So it may be that we may be the only one, right? That I'm aware of. There may be others, but those were the two that were really closest to what we did. And
this also leads to the importance of fundraising and a nonprofit approach, maybe private funding, so it can't be killed.
I have another question. And it's probably like really stupid, but you'll get over it. I know that I've read like meeting people online in like England and stuff like that. They have like a similar thing that you're talking about where the ambulance comes out and they evaluate and they choose to take the person to the hospital. They choose to treat them there. And now, have you looked at their system to see if what you guys could use from what they were doing? It's my question.
We haven't, but I'll tell you where we did get the idea. No, there's no new ideas in the whole. It was in New Brunswick, Canada, where they had created in their national health program and it's it's a relatively small province and right off of Maine, but they actually developed this ambulance-based paramedic service. And a few years ago, I went up actually to see it. It was very impressive. So yeah, there's a lot to learn outside of the U.S. But in this case, it was really, we didn't have to go to England. New Brunswick was really a great model, and that's.
I was just wondering because of funding. Obviously funding is humongous, and that's what people look at first before anything. To me, that's what I see. But I was just wondering. I don't know how they fund it in England or even New Brunswick. Or how they tell people they fund it. I guess
they do it. I know New Brunswick is funded because Canada has the province related single payer system.
Right.
So the government of that province made a decision to fund this as a service, I'm not aware of this. I haven't gone beyond New Brunswick. It was, I have seen that. Right?
Here's where politics and advocacy intersect here.
Right.
For me personally, when I first heard about Obamacare, I thought, boy, single payer, that would be great if everybody would do what Mass Medicaid does, and we could have BCMG countrywide. I think we're on the right track. It's the implementation. And that's the trouble. If CMS is the one provider, which it looks like it would be, that's the Medicare for all, I don't trust it because in my opinion, they're spending a lot of money on accountability and software and data collection rather than on the actual care. So it kind of depends. And in a way, it's a double-edged sword, because in Canada, you either have it or you don't. And here, one advantage is that if one insurer doesn't cover it, maybe another one will, or you can try to raise private money to cover something.
I just want, we're a little over time, and I just want to make, respect everybody's time. It's 12:36 right now. I know that there still might have been a couple of questions, and maybe if you want to ask those, I think Abby had one, you could certainly reach out to Dr. Bergman or Dr. Master. This was amazing, really, really fascinating and great discussion. I think we could talk about it forever. I mean, there's so many things that are wrong, and it's with the system, and it's really exciting to hear what you both are working on. And it sounds like lots of people here would like to, I know I would like to continue following the progress of it and find out ways that we can help and support you. So
you have our email. Don't forget the B, the second B.
yes. And
if I don't get back to you, it's because I didn't get your email.
No, and I'm going to send out it's okay for me to send the slides, but I won't send it until that one is corrected. And I'll send out some of the resources and I think something else that you had talked about. But so you'll all get that this week.
And certainly I can talk offline to you and to Jane and see what could be done. I know Maria has some really great ideas, and this is where putting our heads together is going to really make the difference.
So I'm going to work on correcting that email, Sue. Is it just, it's only adding 2 B's in there, right?
You have Susan Bergman. It should be Susan B. Bergman.
Susan, in all one word. Okay. Susan.
All one word. Susan B. Bergman.
Got it.
At Gmail.
At Gmail.
Thank you.
We got it. I'm going to get, I don't know. Okay. We'll get that corrected.
We'll take care of it. Don't worry. And lots of you probably recognize also or know Susan from, she's been coming to many of the different support groups, and she's a terrific resource and support for all of us. So
I'll figure out a way that I can be utilized in a way that.
It's fantastic. It's really been wonderful. We all appreciate it. All right. Well, yeah, thank you so much, everybody. And hope you have, Abby here, instead of just retiring, you're taking this on. It's amazing. Okay.
To be honest, my own patients thought I was topping out, but I promised them that I was going to keep working on it, but figure out a way to actually make it happen rather than have it kill me. Literally.
So anyway, if Dr. Bergman or Dr. Master have a couple of minutes, and there was anyone who did have any, I think we may have had somebody who did have a question. If you do have a minute to, and
I can
please
stay on for a couple minutes.
Please, you can all, go about your day. It's beautiful out. And thank you all so much.
Thank you.
Thank you all. Great job. Thank you.
Thank you.
Great presentation. Thank you.
Thank you.
Thanks all of you.
Abby, did you have?
No, I just, I put some things in the chat and we can chew on them. Yeah, if anyone has a more, sort of up to the minute urgent question, they're welcome to have my turn.
Well, I have the same concerns that you do, that the basic problem is that the pay for the people who do this work doesn't match the difficulty of the work, and it doesn't pay a living wage. And if you are trying to choose between getting, I don't know, $16 an hour to flip burgers and $11.75 to do PCA work, unless it's a labor of love, the thing I think what we have to really look at is how can we supplement, the government funding, because it's clear that you can't do everything. And I think what they respond to is a really concise, clear message with data to back it up. Otherwise, they won't even talk to you.
Yeah, I don't have any answers.
Well, let's keep thinking about it. I think that if you go back to the 80s, the 70s and the 80s, they didn't have the answers either, but they knew what they wanted it to look like. So that's why I think we're asking, rather than what's the matter, what matters to you and what would you do about it? Maybe we can all put ideas together. To me, I think it's fundraising.
I'm really struck by, and I can't remember the way you phrased it, the fact that like insurance companies make decisions about DMEs
Yes,
instead of, what did you call it?
I called it Mother May I.
Right.
But what happens is the prior authorization
Instead of being
process.
the clinical, who did you say should be
Right.
making the decisions?
Well,
Clinicians.
Clinicians. We call it individualized care plans, clinically determined between the clinician and the individual or family. I mean, it's really a joint decision, and out of that comes comes the answer. And sometimes, and it's different in different circumstances. People need different levels, and
Yes,
depending on what kind of support. So it's anything but a one size fits all,
Right.
but it's that model where that, and the language is, it's delegated authority to develop and implement individualized care plans for long-term services and supports and durable medical equipment. That's kind of the official way to.
I mean, up to now, it's been a non-starter on the federal level. And I think, again, it depends on who you talk to. I asked a group of doctors from Chicago about this who were working with their legislators. And they literally said to me, I don't understand why the wheelchairs cost $50,000 when you can buy a wheelchair, for $3,500. What's that about? Who needs that? And it's that kind of who decides what's medically necessary. And that's really the decision. We go to school for a reason. And if you're living with a situation for years and years, you know what you need.
Yeah.
Probably those in charge of the official purse strings are afraid that, there'll be a sort of gradual slippery slope expansion of, benefits that ensues because, the care providers are full of empathy for their charges. And I'm wondering if, there seems to be a little bit of a national trend toward managed care, sort of the HMO model. Does that intersect with what you're doing?
Yes, very much so. And it's really, that's why they talk about populations. And right now they seem to define populations either by where you live or what insurance you have. If you could look at populations according to how many chronic conditions are you trying to juggle? What's your age? What, you know what I mean? Think of populations differently, because they're right. There is some standardization. There's standardization in SCI protocols too, but you can't mush everybody into one big pot. It's like, that thing on Friends where Rachel made a trifle that had whipped cream and bananas along with beef Wellington in one big jar. It's not going to work very well.
Well, but one of the advances of the last 15 years or so, it's been these Medicare, Medicaid combined dual eligible programs. If you're duals and you have an entity that's willing to take risk, then you can certainly then say, have individualized care plans. And that exists in there are models, the PACE programs for frail elders are all done by individualized care plan, but that PACE program is a clinical program that takes risk. We took risk at CCA. And in fact, the evidence was when you did that, you actually saved money.
Well,
because,
here's the problem though.
Yeah.
You can have the care plan, but in the case of the adjustable pressure, the low air loss beds, there are no vendors that will deal with the home market anymore.
That's changed. That's right.
And I think that's what's been happening slowly but surely. So you can have the care plan, But if you can't get what's in the care plan, it's just a piece of paper.